So in this lecture, we're going to be looking at how you might apply the capabilities approach in ethics to the questions of disability and healthcare. And in some ways, the theory was designed to handle these particular types of ethical issues. So, since the capabilities theory is a type of social contract theory, it's going to say that all governments have an obligation to provide citizens the minimum capabilities that are necessary for a fulfilling life, and that therefore citizens have a right to those types of capabilities. That's the essence of the capabilities approach. And it was in some ways developed as a response to utilitarianism and other types of theories that argued for an equality of treatment between individuals. Because since the capabilities theory requires minimum capabilities, it may simply take much more expenditures to help one person reach those capabilities or those minimal levels than it takes other people, just in the same way it takes sometimes more people, some people, more money to educate them, to get them through high school, than it takes other people. So perhaps you're familiar with this way of understanding the differences between equality and equity. So in reality, people may have lots of advantages or disadvantages. In this case, we're considering the analogy of watching a baseball game. And equality of giving everyone exactly the same size box, of course, wouldn't produce the minimal amounts of visibility that would be necessary for you to see the game, which is analogous to the basic capabilities necessary for a fulfilling life. The tall person is able to see it. The medium person is able to see it with the one box, but the shorter person is not able to meet that minimum capability. Equity would not be equality of expenditure. It would be giving everyone what they needed to have an equal access to that particular capability. And many people now point out that real justice requires not just equity in fixing systemic structures that get in the way of our capabilities, but also finding a way of creating systemic change that eliminates the barriers that stand in the way of our capabilities. So real liberation would be getting rid of the fence. And we'll see that type of progression in our understanding of disability as well. So one of the typical models of disability was that it is people who are disabled because they have objective features of their nature, that Aristotle would say, which prevent them from having some of the capabilities that they would normally have. And that therefore it's these defects in their body or their nature that cause the disability or cause their inability to enjoy some of the things that we think are necessary for a fulfilling life. So in that case, the medical model, which was influential throughout much of the 20th century, the problem is with the individual who has various different defects, and they were treated as if they were medical problems, as if they had to somehow be ameliorated by various different types of medical treatment. What's become the standard model in the latter part of the 20th century, in the 21st century, is what's called the social model of disability. This realizes that different people have different physical abilities, and it's not people who are disabled, but that disability is a function of the social barriers that a society puts up against you exercising certain capabilities that you have. The idea is that everyone, not just certain people, requires certain help and certain social investment, certain bits of social capital to allow them to function in society. There have to be roads in order for you to drive somewhere. There have to be crosswalks in order for people to effectively navigate cities. And what counts as disability isn't determined by the person. It's determined by the relationship of that person to the ways in which the society and the environment set up barriers to their performing the activities and accessing the opportunities that are necessary in that particular society. So, at St. Anselm College, whether you're disabled or not depends upon not really upon your abilities, but whether there are ramps and elevators and doors that someone, for example, on crutches, or someone who was weaker than many of us, or someone who was shorter or taller than many of us would experience. So we wouldn't think that left-handedness would be a disability unless all of the chairs available were for right-handed people, and it made it impossible for left-handed people to write. We wouldn't think that being non-hearing is a disability unless there were no closed captioning or ways in which you could, in which hearing-impaired persons might be able to participate in educational and entertainment opportunities. So the social model of disabilities talks about various different impairments within an individual, but it's not the person who's disabled. Disability is a property of the environment that gets in the way of various different types of individuals who have various different types of impairments, as we all do, in participating in the benefits and opportunities in that society. So you can watch these two videos that will help you get clear about the differences between the medical and the social view of disability. In particular, the second one that tells a little parable about how in a world that was designed for people in wheelchairs, it would be the people who are today called unimpaired who would be the disabled persons, because the society would be set up to exclude them and to make it impossible for them to avail themselves of many of our opportunities. So that may help you understand the social theory of disability and the claim that disability is a function of how a society allows all of its members to participate in those basic capabilities. There are a contemporary theory of disability tries to go even further and recognize that not only are there physical accommodations like ramps, elevators, wheelchairs, that make the capabilities of a society open to everyone and that determine the degree of disability of a person. But maybe even more important are the sets of social norms and systematic ways in which we treat and regard other human beings as persons in virtue of their disability. So one of the problems with the medical theory, and one of the problems that we've inherited in our culture from the influence of Aristotle that we saw in virtue theory, is that there's a particular human nature that defines what's best, a goal or a purpose or a perfection for human nature. And anyone who doesn't fit into that norm is seen as in some way defective. So the idea of the medical model that disability was a problem with the person stems from that teleological view of Aristotle, that there's a model or perfection of the human nature, and that deviations from that nature are imperfect. So crip theory, as it's called, is a combination of what's called critical disability theory, which is contemporary social theory that attempts to apply this social model of disability to understand the barriers put in the way of various different types of impaired person, along with queer theory. Queer theory is a type of theoretical approach to gender that attempts to destabilize and invert many of the gender categories that allow us to understand non-binary, male, female, cis, and LGBTQ persons. And it attempts to articulate and break the boundaries of the various different norms and standards that restrict our identities and our opportunities based upon gender. So crip theory tries to do the same thing with disability theory. And this is sort of our first encounter with the idea of social norms and systemic modes of treatment. The basic idea is that how we even think of a person, how various different social entities like marriage, maleness or femaleness, and crime and deviancy all come into existence through the existence of systematic sets of rules or norms, sometimes explicitly stated like laws, but sometimes implicitly enforced by various different types of shaming and social attitudes. So a constitutive rule is like a rule in a baseball game or a game in which things come into existence in virtue of sets of rules. There are no strikes and outs in reality. There's no such thing as money apart from certain sets of rules that human beings bring into existence. And knights and queens and outs and strikes and dollars come into existence through these systematic sets of rules, just in the same way that entities come into existence in a game. So being disabled and the way in which that's conceived in terms of your identity and the effect that the way in which people treat you and the way in which people regard you affects your identity, affects your worth as a human being, are all part of this systematic social structure. So there are behaviors that exist as playing out certain norms. There are the norms and beliefs that determine the structure of the society. And then there are attitudes that are informed by these, and all of these influence each other reciprocally and bring about the realities, the experience realities that we have as part of the social system. So crip theory is interested in breaking down the ways in which we understand disabled persons and normalizing what we call disabled. So a disabled person, remember, would no longer say that they're disabled. They would say that disability is a function of environment or society that doesn't accept them, that treats them differently and imposes barriers on them. And it would even begin to resist the idea that there's something wrong with them or deviant or abnormal about them. So, for example, many non-hearing persons, after having lived in schools that have American Sign Language and allow them to function just the same way that people would do in other language communities, no longer view deafness as a type of disability or impairment in the same way some blind people would think that way, because it comes along with other types of enablements. So people are, sometimes you'll hear, differently enabled rather than disabled, or people may talk about their objective impairments, but they don't talk about their disabilities as affecting their person. So crip theory is interested in some of those other capabilities of capability theory, like the right to affiliation and the right to emotional richness in one life, the right to be seen in have a certain type of dignity that's equal to other people and not feel humiliation. So perhaps you've heard of or seen the documentary that's on Netflix now. There's a link to it in this slide called Crip Camp, which tells the story of some of the intellectual origins of crip theory. Crip Camp was a camp for disabled persons in the late 60s and early 70s that helped give rise to the movement that generated the Americans with Disability Acts of the 70s and the 90s. So you can watch this film by one of the most prominent queer theorists in the world that we'll have opportunity to talk about when we talk about systemic sexism, Judith Butler, and her conversation with a impaired person, talking about not just the different theories of disability, but also the way in which our bodies, how we see our bodies, and our abilities and culture are determined by social norms and attitudes. So you can watch that. So you can find some more resources on disability theory and disability here if you're interested in reading some more. So if we're going to talk about the ethical issues involved using capabilities theory in disability, we have to ask some other more difficult questions. In the United States, there were two main disability acts. In the 1970, the Rehabilitation Act Preventing Discrimination introduced the idea of special education in schools. And then you may be aware that we're just celebrating the 30th anniversary of the Americans with Disabilities Act from 1990, which tried to eliminate discrimination and provide equal opportunity for disabled persons in a wide variety of different areas. And that's become a focus of various different types of discussion. One of the questions we'll ask in all of these cases involving capability theory or basic rights is how we balance benefits versus costs. So in the United States, disabled persons have the right to support under disability insurance through Social Security, which is a type of health, age, and disability insurance that we all pay into. Anyone who works has money deducted out of their paycheck for Medicare and Social Security, which covers those. And as you can see, since the passing of the Disabilities Act in 1990, the amount of money that it costs to pay for the care of disabled persons has increased at a fairly uniform rate. Of course, that may also be because of increases in population and other things. But we have to, at a certain point, one has to ask, how much more do we have to spend in order to provide everyone with the minimal capabilities? Is there a limit to how much we have to spend? And this becomes even more prominent in discussions of education, since every local school district is now embroiled in various different types of funding crises, partly because that 1973 Act, even though it gave certain rights to special education, only committed the federal government to paying for a particular portion of those additional costs, maybe 40%. In actuality, they pay much less. So local and state governments find themselves strapped to pay the deficit in the cost for special education of various different types of impaired students to give them equal opportunity to the capabilities provided by education. The chart that you see here is just an example of one representative school district. You can find different amounts in different school districts, but the cost of educating a special education student can be almost double the cost of per student of educating a general education student. So much of the debate over education and the level of our funding of education involves asking just how much extra are we willing to spend and who has to bear the costs of those. And of course that's tied up in lots of other debates that we have as well, like the debate over charter schools, different schools that are paid for with federal or local school funds, but which typically do not accept special education students. so therefore drain the funds that would be available for treating these differently enabled students, and also segregate their experience and make them experience themselves as different. So we'll see that healthcare is going to have a similar set of issues. And just as the capabilities approach was designed to handle the question of disability, since it argues that it's a basic right that for everyone to be provided with the minimal capabilities necessary for a fulfilling life. So it would argue that the fundamental disabilities are ones that should be removed for all impaired persons, and that the condition of the social contract that makes a government legitimate is that it provides us with these basic capabilities. And of course, the same thing is going to be true for healthcare. Even more basic capability, the first capabilities of life and health and bodily integrity. So, unlike the moral approaches we'll study later that are most often used in healthcare administration and thought, utilitarianism, which simply adds up the economic costs and benefits of providing healthcare, and tries to balance them out to produce the greatest benefits for the greatest number. The capabilities approach deals more with the whole person and all of their fulfillment rather than just the monetary costs of keeping them alive and healthy. And it also, again, requires not an equal expenditure, but requires everyone to have a certain minimal degree of support that's necessary to give them those capabilities. So the capabilities approach obviously thinks that there is a legal right to healthcare, at least healthcare that meets the minimum requirement for those basic capabilities of human fulfillment. And the reading that we're doing by Pianand on capabilities in health uses a couple different examples to show how the capabilities theory might be applied. The one example they use is the right to die, which has to do with end-of-life questions and whether it's morally admissible to allow an older person who is suffering from a terminal illness to end their life or to cease care or have a non-resuscitation directive or disconnect themselves from life-preserving mechanisms or technology. When we get to natural law theory, we'll look at Catholic positions on this and natural law positions. But the author considers the different ways in which capabilities theory will approach this. Utilitarians will approach this by just asking, do you avoid unnecessary pain by allowing someone to end their life to avoid a decreased happiness and decreased welfare? The capabilities theory includes the ability to avoid non-necessary pain as one of the basic capabilities of sense and thought. They allow sovereignty over one's body as a basic capability. So the ability to control when one ends one's life might be considered a basic capability. And probably most importantly is the capability of practical reason, which is the ability to form your own conception of the good and to make your own choices about what's ethical, about what's moral, and about how you want to pursue the good in your particular life. So the author argues that the capabilities theory would clearly argue for a right to die based upon the minimal levels that are necessary to preserve that basic capability. So despite the fact that life and health are basic capabilities that are necessary to fulfill yourself, under conditions where it's impossible to maintain life and health in ways that fulfill human nature, They might argue that to pursue these other basic capabilities, it's necessary to give you a right to die, so as to preserve the basic human dignity that's necessary for a fulfilling duration of the ending of one's life. The other example that the author considers that may be more important for us is just the allocation of health care. Who should get it, and how do we decide what the best way of allocating our health care dollars and abilities are. And of course, this comes into play in conditions like COVID, where conditions outstrip our ability to care for persons. So we have to decide who's going to get our limited number of ventilators, who's going to get our limited number of ICU beds, who's going to get our limited number of vaccines and tests. And typically, healthcare providers have solved this using something like utilitarianism or cost-benefit analysis. They've asked, who stands to benefit most from these types of medical interventions, and who stands to benefit least. And the basic argument that was often used was called a fair innings argument. Has everyone had an equal opportunity to take advantage of all of their times of life or their innings? And how much time do they have left that could be improved by health care? So the fair innings argument would say that we should be less likely to give older people the ventilators and ICU beds and vaccines because they have less quality of life. An intervention that saved a 30-year-old person would save lots more years of life than an intervention that saved a 75-year-old person who is going to die anyway of natural causes within 10 or 15 or 20 years anyway. So the authors try to consider how the capabilities approach would handle that differently. And it's not clear whether that the authors completely disagree with the conclusion of the fair innings argument, but they think that capabilities theory can give a better accounting of the moral issues behind the rationing or allocation of health care. But it should be clear that whether the authors would agree or not, that capabilities theory would argue that all human beings, including old no less than young, have a right to the minimum capabilities for flourishing, that they're entitled to health care as well. And we've already seen that in Capability 7b, which is entitled Affiliation, but includes the ability to have self-respect and not be humiliated, to be treated with dignity and equal worth. We can see that people object to the idea of death panels or rationing of health care based upon age as an affront to the dignity of old persons. We wouldn't be able to be happy and live a flourishing life if we had the idea that we were somehow lesser human beings because we were older. So you can see that even within capabilities theory, some people, like the authors, argue that it might justify an allocation of health care, whereas we can also give a very clear justification within capabilities theory that you shouldn't be allocating health care based upon age, that everyone is entitled to the minimum capabilities for flourishing that health care provides, and that recognition of dignity and self-respect requires that there be no discrimination based upon irrelevant characteristics. So our debate on this is going to take a much more difficult and more general question, whether the government is required to provide health care to its citizens, and how and at what cost. So capabilities theory, it's clear, suggests that a basic human right is a level of health care that provides the requirements of life and health and bodily integrity that are necessary for that bare minimum capability that's necessary for human fulfillment or human happiness. The difficulty, though, is asking then, as in all rights theories of ethics or of justice, is asking how do we balance one set of rights against another in cases where they come into conflict. We all recognize that your right to the pursuit of happiness or your right to freedom of religion ends where it comes up against other people's right to life or other people's right to happiness or other people's right to freedom of religion. And there are often quite difficult questions of how to reconcile conflicts between different persons' rights and different rights. So how can we balance the minimal capabilities that a universal government-provided system of healthcare seems to require with the threats to other capabilities that the cost and necessary force needed to provide and ensure a universal healthcare system might cost. And there are also significant moral questions about who exactly is going to bear the cost and how. So in the United States, you're probably familiar with how we solve this problem. We have government-provided health care for old people called Medicare. We also have government-provided health care for poor people called Medicaid. And Social Security also provides medical care for disabled persons. And all of those are really like, they're not so much paid for by taxes. They're paid for by an insurance fund called Social Security and Medicaid and Medicare. Again, those are deducted from every employee's paychecks separately from their federal taxes and are supposed to be then invested in a trust fund which will then pay for Social Security, Medicaid, Medicare, and disability coverage. But other than that, the requirement for health care is covered by private insurance companies that employees pay for and that individuals pay for. Unlike every other developed nation in the West, which has some type of government-provided health care. So these aren't exactly moral issues. Much of the debate about universal health care, especially in the United States, depends upon questions of what's the most efficient way to provide health care, and depends upon our judgment about various different matters of fact or empirical matters, such as how much are we paying and what's the quality of that health care. So these charts, and you can click on any one of them to take you to the origin of that chart if you wanted to find the source of some of these statistics. But I think you can see that almost any objective rendering of the United States' way of handling healthcare with other countries would agree that the United States pays much more for their healthcare than other nations such as Germany, Japan, and Canada. And that the health care that they get for that is much worse. We're last among these countries in infant mortality. We're last along these countries in life expectancy. We're last among these countries in the different types of barriers to health care that we set up against persons with low incomes. So those are some of the basic facts behind the American debate about whether we ought to have some government-funded health care. And again, much of the debate comes from, ought it to be subsidized as in Obamacare, ought it to be based upon Medicare as in the Medicare for all option, ought it to be some other form of national health care based upon English or Canadian or European models, or ought it to be just like what we have now, provided by private companies with a safety net for poor and old persons. So let's look at just briefly some of the opposing arguments. The capabilities argument ought to be clear that health and bodily integrity are basic human capabilities, therefore every government has an obligation in order to be legitimate to provide its citizens with some basic minimal level. And of course, we might wonder, does the current system of providing health care for the very poor, the very old, and the disabled, does that meet those requirements, or should there be government-provided health care for everyone? Of course, part of the problem is that health care has become so expensive, and the number of people who have and can afford some type of insurance has decreased so much that now healthcare is one of the most significant costs that human beings bear in America. So that a working person who doesn't meet the disability standards or Medicare finds themselves reduced to poverty by the costs of healthcare. And sometimes it can be advantageous to keep yourself in poverty to be able to take advantage of the health insurance provided by Medicaid. So, there's those types of inequity in the system that we have. So I think we can see that we can find some evidence or some common grounds that there seem to be limits about how much we will sacrifice to provide basic capabilities. We want to make sure that the cost of providing one capability doesn't reduce the capability of others below minimal levels in other cases. So during an emergency, for example, we might find that we just can't provide everyone with all of their capabilities. We might prioritize and realize that we just can't afford to give a minimal level of health care because we just need food and shelter. We have to suspend schools, for example, even though that's a basic capability that the government ought to provide. In order to provide other types of bodily safety and food and shelter and things of that type. I think we all probably might recognize that under certain conditions, that there are some types of illnesses, and maybe at the end of life, certain types of deteriorations of our health that make it so that almost no matter what you do, you're still going to die, and the cost of prolonging life for even a few weeks might be more money than you might earn an entire lifetime. So you can judge for yourself, but for me, if I contracted an illness and the cost of treating that illness, say, was 5 times the amount of money I would earn in my lifetime, so that it would not only completely impoverish me, but impoverish all of my children for many generations down the line, I might judge for myself that it wasn't worth trying to have that treatment. And nowadays, again, the cost of healthcare has increased such that treatment for sometimes even fairly routine things like an appendectomy can run into the hundreds of thousands and maybe even $1 million. That is, many medical procedures now can cost more than many people would make in their entire earning life. It certainly seems in some cases we'd agree that there are limits to how much we sacrifice, just as there might be limits to exactly how much we're willing to spend to put in ramps and accommodations to allow everyone, no matter how severe their impairment, to enjoy basic opportunities. So it seems like there might be limits to how much we're willing to spend for various different types of medical procedures. And again, we don't want the cost of providing these minimal capabilities to get in the way of the expenditures that provide shelter and education and other basic capabilities. Probably more fundamental types of arguments are like the ones that we talked about in the origins of social contract theory between Hobbes and Locke, between libertarians and liberals. A libertarian, remember, would suggest that our social contract in a government really doesn't include the promise to provide all of these basic rights. It just includes the promise to protect us from the war of all against all, so that people don't kill us. Government should protect us from being invaded by foreign countries. They should provide us with the basic infrastructure that we need to live, and they should provide a police force that prevents other people from killing us. But apart from that, the only obligations we would have would be the obligations to that we incur ourselves through voluntary contracts and purchases. So, some libertarians would suggest that we don't have an obligation to help other people in that way. So you may want to think, are there common ground arguments that they would use to suggest that in some cases we don't think that we have an obligation to provide other people with basic requirements or basic minimums that they need to have the capabilities for fulfilling life. So we might think, for example, that normally we don't pay for the food and the rent of other persons. We might pay taxes to support shelters and food stamps for the very, very poor. But normally we don't subsidize the food and the housing of everyone. No one is proposing universal housing provided by the government or universal food provided by the government. And those are basic capabilities as well. So a libertarian might argue that those are common ground examples that suggest that we shouldn't be providing government-provided health care either. And part of these are tied up as well with capitalist arguments. We're going to talk about capitalism a little bit later. But apart from arguments about whether we should have health care, there's also the question of what's the best way of providing health care. So if the government provides health care, it will have a cost that's borne by taxpayers, and everyone will participate in that cost through the tax that they pay. It may be that competition and profit from individual providers that are motivated by attempts to make profit will make our production of healthcare much more cheap and efficient, and that most of us will end up paying less for it if we have to pay for it ourselves than we would have to pay for it in taxes if the government took over the production of healthcare and did it inefficiently. Again, the facts that I suggested are pretty clearly established in the previous slide, suggest that that probably isn't the case for most developed nations. We pay more and get less for our health care than any other developed nation. But we can see how there might be room for some type of disagreement. At least those are the types of arguments you often hear. One argument that sometimes people give is that sometimes waiting periods for an operation or a procedure, sometimes in Canada, are longer than in the United States. That isn't true of England, and the National Health Service usually delivers free health care more quickly than Americans do for profit. But at least it's certainly an argument that some people hear, that some aspects of health care might not be as good under a national health care system. So besides moral arguments, we might also argue about what's the best way of doing it, which is not quite a moral argument, but is an argument about which is the best way of providing the morally obligated health care that capabilities theory says every government has a required to provide. And again, the more fundamental arguments that I'm sure will come up during our debate are going to be libertarian arguments that suggest that we're not obligated to provide those types of rights or capabilities, and that the government is only required to provide those things that protect us from the war of all against all. So we'll talk about those in class, and then we'll have a chance to talk about them in our debate.